Okay. Here's that AC joint. Usually the problem is in the anterior portion. Might be lateral, might be posterior. We just palpate around, find where it's tender, needle into it. Sternoclavicular joint. This one is a little bit more anatomically correct here. Palpate around, needle in a downward angle, not straight perpendicular in where I might miss and get into the anterior neck triangle, not upwards either. But again, this is actually safer than kidney 27. It's safer than stomach 12 because there's this thick bone and ligament here protecting the pleural cavity. Okay, definitely safer than Ren 22. And then
Actually, when there's a drop off, like off here, and this is drop lower.
That step off deformity,
step off, yeah,
right?
Step off. Which so there's a ligament here that actually is going to be. When we're working after that, is it stretched out?
That's right, exactly, yeah. So what Kevin's asking is the step-off deformity, we looked at the slide earlier, that's where there's a large gap in between the clavicle and the acromion, and a severe, sprain will actually tear those ligaments completely through. So there's nothing there, right? That we can't do much about, except to needle the coracoclavicular ligaments that run from the coracoid process up to the clavicle, and those don't usually get snapped through. So those are usually intact, but those are the ones that as I said, I want to needle in a lateral angle, never medial, because medial it's too easy to wind up in the rib cage, okay? But I can needle those coracoclavicular ligaments between the coracoid process and the clavicle from a lateral angle, okay? So a step-off deformity is going to make that gap much easier to find, but harder to get a good result if there's a big one because those ligaments may be really torn up. Then here's the glenohumeral joint. We talked about needling the anterior from about 11 o'clock to 4 o'clock. That's the part of the glenohumeral joint that is most prone to injury. The slap lesion, the superior labrum anterior to posterior, that tells you exactly the needle angle. Anterior to posterior, posterior to anterior, needling across the top of the labrum with a needle. The Bankart lesion, or the TUBS, the traumatic unilateral Bankart lesion, usually requiring surgery, but it may not require surgery if you get into, that's more the anterior portion of the ligamentous capsular structures, needling straight into them. And then the inferior portion that you get through the axilla with the arm abducted and externally rotated, you're getting in there in between the humerus and the glenoid fossa. Okay?